Hi and welcome to TTAPS. This is to gain nervous system expertise. There are 4 parts to TTAPS. This is part 1, where we're dealing purely with reflexes and possibly some minor scar tissue involved. When you take care of that, then you have denser scar tissue outlining the joints. So TTAPS part 2. The first part of TTAPS Part 2, we show you how to very easily, within a short space of less than 10 minutes, test the strength of over 200 muscles in the body and lightly tap on one spot for that particular patient, no matter whether there's 3 weak muscles or 55 or 75, and they all instantly gain the strength back, excepting some areas that may have heavy atrophy, which are usually in the feet. But some of those surprisingly come around very quickly too. The second thing we show in that seminar is to palpate the whole body for painful areas. And then lightly tap, just like that, one non-painful spot in the body according to that patient's profile, and instantly all the pain is gone, except for some areas that are highly inflamed, but even those within a few minutes drop to half or less of what they were. Then, several minutes later, most all that inflammation is gone as well. Now, this is outside what you normally learn. And by the way, the muscle testing is not applied kinesiology muscle testing. It's according to Kendall and McCreary, who are physical therapists. Now, the rest of the seminar is dedicated to taking care of the outlying dense scar tissue. Now, this is unlike other seminars, such as ART, which admittedly to them take about 4 to 6 treatments to clear one muscle, or Graston, which takes about 6 to 10, or transverse friction massage, which in their own manual takes about 10 to 20 to clean out a given muscle. Most of ours are taken out with much less effort on your part, much less pain to the patient. Total treatment time generally less than about 30 seconds, usually corrected in one treatment with very few exceptions. Quite different from what you've been taught. Now, the first and second seminars, when you've taken care of those, then you're left with the dense scar tissue inside the joints. Now, the first part of that seminar we teach is how to stand a patient up, feel down their paraspinal musculature, feel the tender and very taut areas, and lightly tap on one area on that patient, and immediately the tension goes out from the paraspinal musculature and the pain goes out, literally in seconds. Now, the first 3 seminars are dedicated to getting the nervous system back in shape. By the way, on the end part of the rest of that first seminar, we teach you how to very easily and with a lot less force than you've been accustomed to adjust vertebrae, and we take you through the cranials and the extremities and the vertebrae. And we show you amazing things that happen when you do it, far past what you learned in other seminars. And once you've taken care of the nervous system, which controls all the secretory and excretory events of the body, then we teach the pure body chemistry. Now, one of the things that you're going to notice as you go through these seminars is you need much less nutritional intervention. And a lot of people who are not responding to nutritional intervention, or they have to keep on taking it, were actually nervous system issues. So you're going to find out that you don't need that much, or you need a lot less nutritional intervention than you ever thought on any given patient. The fourth one, body chemistry, we teach you about negative feedback loops in the body. And we show you the progression of what happens in chemical changes. So far from being a this for that type of seminar, that is, this nutrient for that symptom, you may need to evaluate, and you're going to find that you need to intervene maybe 3 events before where the symptom occurs, such as low testosterone, or maybe one or two past that to get the change in the testosterone. There are many other examples of this. And it's a very different approach, and you're going to find that you're needing a whole lot less nutritional intervention, even when it's necessary, than you ever thought you would. And you find that changes occur very quickly in all four of these parts. So welcome, and let's get started with part one. Each part of TTAPS stands on its own and gets amazing results, but each one complements each other. So I would urge you to take each part and you'll see what I'm talking about. In college, we learned about the all or none law, meaning that when a nerve starts to fire, it completely fires. When a muscle starts to contract, it completely contracts. But we're going to show you where even in the same textbooks, the textbooks don't state that same thing. Now, one of the things we're going to springboard off of is the myotatic reflex. And this part one is mainly about myotatic reflexes. Now, Mazion's Illustrated Manual of Orthophysio Neuroclinical Diagnostic Techniques says the deep reflexes, also called tendon reflexes, redundantly the deep tendon reflexes, are also called the stretch reflex or myotatic reflex. This is the same thing that you use a reflex hammer on the patellar reflex. And when you're doing the bicep tendon, you put the thumb here, you tap the muscle instead of the tendon, and the tendon jumps. So you can apply this reflex on the muscle or the tendon to make it work. In fact, anywhere on the muscle, anywhere on the tendon. Correlative Neuroanatomy and Functional Neurology, Chusid's 16th edition. It talks about muscle tonus is a state of continuous mild contraction of muscle. And mild contraction, what does that mean? That means that it doesn't fully contract, it doesn't fully relax. So that all or none is a myth. And it's in the same manual. The stretch reflex is considered essential in maintaining muscle tonus. Now, most reflex arcs include at least one internuntial neuron between the afferent and efferent fibers. The stretch reflex has no such internuntial or intermediate neuron, and the afferent neuron makes direct contact with the efferent neuron across a single synapse in the spinal cord. But we're going to find that that isn't true either. So, one of the first things that I say in every part is forget everything that you thought you knew about anything, because it's probably not exactly true. There's probably a better and easier way to go about it. Stretching of a muscle stimulates its muscle spindles, and that stimulates the gamma motoneurons, which then stimulate the alpha motoneurons. This is using the intrafusal and extrafusal fibers. And rather than having to do like applied kinesiology and push them together or push them apart, you merely need to tap it to get the same response. Most stretch reflexes include the gamma loop, and this is what chiropractors call the safety pin cycle. But in regular science circles, it's called the gamma loop. So when you're talking with another professional, either a physical or occupational therapist or MD, to speak their language, you talk about the gamma loop rather than the safety pin cycle. Next, tone is lost or diminished when the reflex arc is interrupted. Wait a minute, diminished again means that you don't have a full contraction or relaxation. Here again, we've been lied to, and in the same text, in another spot, we learn that the all or none principle really is not true. The spinal cord is the seat of the stretch reflex, which functions in the maintenance of tone or static activity. So everything that we're doing is going to affect tone. And this is very important. A nerve fiber may be excited from its own cell body, or by a variety of mechanical, thermal, chemical, or electric stimuli applied anywhere along its course. So keep that in mind because that's very important. Just the same as the stretch reflex can be applied to the tendon or anywhere on the muscle. You can have excitatory or inhibitory postsynaptic potential. An excitatory postsynaptic potential can turn into inhibitory postsynaptic potential. Now, that being said, I want you to think about a couple of things. When you use the patellar reflex, the quadricep contracts, and by reciprocal inhibition, the biceps femoris, or the hamstrings, have to relax. Let's talk about electrical stimulation. When you have somebody who has spasm, you put a tetanizing current on, which is quite painful, and you have to put it on for a long time. The idea is to hypercontract it so it exhausts it and then it finally relaxes. Let's take a look at that. Now we can do that with simple tapping of the myotatic or stretch reflex. We can approximate the ends of a muscle, such as the upper trapezius, and tap up here, make it finish a contraction so it then relaxes. And or go to an opposing muscle, such as the latissimus dorsi that would pull the other way. You tap it, it contracts, and then reciprocally, with reciprocal inhibition, the upper trapezius relaxes. So you can accomplish the same thing very easily with little or no pain to the patient in a matter of a few tenths of a second, rather than using electrical stimulation that lasts minutes and is very painful. Now, the rest of this whole seminar is expounding on those simple principles. We're going to learn how the reflexes in the body work and how easy it can be to get very quick and magnificent results. Let's talk about why a patient's pain is sustained, why they have to keep coming back for the same problem. One thing is you haven't gotten it released. On the other hand, we talk about how long it takes because of atrophy. Well, that's another thing. But another instance, as Melzack and Wall talks about. Now, Melzack and Wall talk about the gait theory, and that's what we were taught. And that's all we were taught about Melzack and Wall. And I've read several of their manuals, and that basically takes up just one or two sentences in each manual. They consider it minuscule. But that's what they're known for in scientific circles, which is kind of curious. The rest of their manuals all go off of something called convergence and summation. So let's talk about convergence and summation. When you get in an auto accident and you're rear-ended, as Murphy talks about, you're extended and your neck rides up over the neck rest, flips back, and then it's springboarded forward. Now when it springboards forward, your arms are grabbing here, and you get this, and the legs are the same thing. Now all this happens rather simultaneously. So you have the neck whipping, and you have a jolt to the hands, the wrist, the arms, the elbow, the shoulder, the chest, the back, the feet, the ankles, the knees, the legs, the hips, the low back area, the middle back area. So all these happen rather simultaneously. Now, the brain is just saying, oh, my neck hurts. Now, convergence and summation says that the brain is identifying all these areas with this neck pain, with the trauma that they took. So the patient notices, well, first you work on my neck and that helped, but then it came back. Then you worked on my shoulder and that helped, but it came back. Then you worked on my elbow, then it helped and it came back. Then you worked on my wrist and it helped and it came back, and et cetera, et cetera. So now's the opportunity to tell the patient about convergence and summation. Basically, you say, well, there may be 5 different things that are helping to cause the same pain, which the brain is identifying with that injury. And we may have to flip 5 switches or 25 or 35 switches. Until all those switches are flipped, the brain is still going to say pain because of that switch. Now, after they're flipped and we got everything released, now we can talk about atrophy and rebuilding. Now, we talk about atrophy in depth in part 2, and we give you all the mechanical things that have to happen and what's involved with that. So make sure you take part 2. Flexion reflex. And that basically is a hot plate reflex. You touch a hot plate and your biceps and your lat contract. This would be flexion of the biceps. And then you have a crossed extension reflex. So the triceps of the opposite side helps to pull you away. Then your whole body withdraws. Now, what happens if the memory of this injury doesn't go away? Well, your body is in a constant state of withdrawal. Basically, the biceps is overly toned, the triceps is overly relaxed and weak, the triceps here is overtoned, the biceps is overly relaxed and weak here, and etc. through torso rotators and all the way down the body. So basically, we have to erase the memory of this injury from the brain in order to get all those muscles to react the way that they should and be in proper tone. Now, the proprioceptors in the palms of the feet inform the central nervous system in the brain of weight-bearing pressure on the skin, palms of the feet and hands. So, let's say that you're walking through the floor at night, you're going to get a drink out of the refrigerator, and one of your children leaves a Lego on the floor, and you step on it. Ouch! And you withdraw away from it. But let's say that you stepped on it hard enough that it caused a little bit of tissue damage and a little bit of scar tissue on the bottom of your feet. Let's say that you're walking around a hot pool barefoot and you don't have your sandals on. So it gets hot and you go, ow, 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 ow. Again, you're in perpetual withdrawal. Let's say that you're walking on a sidewalk, not particularly too hot or too cold, you step on a pebble. You get the same type of response. Ouch! Now, what that translates into is that now when you want to push, your body says, no, it hurts, and withdraws, regardless of whether you're feeling pain consciously right at this moment or not. Now, when somebody is in a withdrawal reflex, that means the signal is maxing out at the brain, and most of the time it's going to be best to have someone not in a neutral position but in the maximum withdrawal position in order to get the best results for this particular purpose. So when somebody is withdrawn, for example, they would be like this, so you would treat them there. But for the purpose of this film, we're going to show you what to treat on the bottom of the foot. So you take very small tip prod, just like this, the smallest tip that you can get that's not a point, and you're going to, in the withdrawal position, just go over the entire bottom of the foot just this quickly, and the bottoms of the toes. And after you do that, you have the patient pull the toes back for a count of 20 seconds. What that does is basically you are putting little perforations in the scar tissue, and when the patient stretches it, now the scar tissue separates. And this is very much different than other ways of taking care of scar tissue that you have to go on a seek and destroy mission. Here, you just perforate it and then you stretch it, it separates. Now you just go back and you're looking for hypersensitive areas. Go back on these areas, and you notice the patient isn't jumping like he was. Now, the first time over, you're tapping just a little bit deeper than the skin resistance. If you don't do that, then you're not going to break up the scar tissue. If you're just swatting the skin, it isn't going to work too good. So you're going from the side, just as if you were holding a pin. You're not going straight in. So you're going just like this, just like you're holding a pin. You're going a little bit deeper than skin tissue resistance. Now, if you find anything that is especially sensitive, notice I didn't say a little sore or tender, you can stay away from those. They'll be fine. Something is especially sensitive, the next time over, you go until the tissue stops you, so you're not going past tissue resistance. And if within 10 seconds it starts to go away, you just hold it until it goes away. If it doesn't start to go away within 10 seconds or it flip-flops, you get off of it for another 20 or 30 seconds. And go to another spot, treat it. When you come back, usually that point will be gone, or then it will go away. So that's how you treat these points. Now you do exactly the same thing on the hand. So let's say somebody is having trouble doing push-ups or something of that nature. Well, you put them back in this type of position, just like they would be in a push-up, and you would treat all over the palm of the hand. And then you would have the person stretch the fingers out for, again, 20 seconds. And again, the first time over, you're going just a little bit deeper than the tissue resistance to basically perforate the scar tissue. The stretch is to separate the scar tissue. Now, when the scar tissue is separated, that takes compression off of the muscles, the skin, the blood vessels, the lymphatics, the nerves. You come back, and that's why the sensitivity is down, because now you don't have hypoxia in the tissue, and the lymphatics are draining better, the muscles are working better. Then you go back on again, just the same way, and you're looking now for any residual, especially sensitive areas. If there are any, this time you hold just until the tissue resistance stops you. If it doesn't start to go away within 10 seconds or it flip-flops, you get off of it. If it does start to go away, just hold it until it goes away. You get off of it for 20 seconds, then you go back on it, then it'll be gone or it'll start to go away, basically every time on that second time. So here you have somebody who can't do push-ups. We've had people in seminars who couldn't do one push-up their whole life. Immediately after this, they do 10 of them. It's because the body isn't trying to withdraw, and therefore is not weakening the pectorals and the triceps. What about here? Here you have people who are shuffling when they get older. It's because the feet don't want to push off, because it has this memory of pain, so it's withdrawing. People have trouble standing up. People have trouble going forward and thrusting down on one foot and then back again. It's because their body is trying to withdraw instead of releasing and pushing. And you'll find that immediately after you do this, as I described, the patient immediately has more strength, simply because you've taken away the things that are causing the memory of the injury in the brain, and now the body can function properly. Now, when you're stuck in a position of withdrawal, it's called a chronic semi-flexed posture. The longer you stay there, the more deconditioned certain muscles get and the more hypertrophied others get. And they can be deconditioned to the point of atrophy. So a chronic semi-flexed posture with the atrophy of the relaxed reciprocally innervated extensors may be observed in arthritis, for example, of the knee joint. So whenever you have arthritis of any joint, you are in a withdrawal position, in a chronic semi-flex position, because your body, even though it's years after the injury occurred and it healed long ago, the brain still thinks that the injury is there, so it stays in the withdrawal position. Now, when it does this, the joint between the flexed and the extended muscles is not working right, and therefore you start getting arthritis and compression of the joint. And in the case of the vertebral column, for example, you have bulging, herniated, degenerated discs. So this all plays into all of those. And we get into those mechanisms very specifically in parts 2 and part 3. And we give you all the science and all the references behind it there, so make sure you don't miss those. Now you have the final common pathway. This refers to motor units upon which there is convergence from many afferent sources. Thus, sensory impulses from many segments involving many types of receptors may influence the anterior horn cells for a time. Now, what are we actually using? What are we influencing when we're looking at all these things? Well, they are some very specific nerves that you already know about because you learned this in college. But you learned it as something just as a definition, not actually as a treatment, not actually as something causing a chronic problem, because abnormal firing of these nerves are causing a prolonged memory of an injury in the brain because of scar tissue associated with them. One of these is Ruffini endings, or Ruffini corpuscles. They are a class of slowly adapting mechanoreceptors, and they are thought to exist only in the subcutaneous tissue. And they respond to stretch of the skin. So this is in the deep part of the skin. Now, because it is sensitive to stretch, this stretch reflex will affect it. And so therefore by tapping or stroking the skin, which also causes a stretch, you can affect these and you can correct the reflex back to the brain. The Ruffini endings are located in the deep layers of the skin, register mechanical deformation within the joints, and more specifically, the angle change. So here in the deep layers of the skin, it is registering what's going on deep in the joint and the angle change. So it therefore can correct that, because as you recall, you can stimulate a nerve anywhere along its course and cause that nerve to fire. Now, muscle memory has been used synonymously with motor learning. And this is going through memory through repetition. Hebb's rule states that synaptic connectivity changes as a function of repetitive firing. So now we're talking about the synapses and the nerves and memory. And this goes to the basal ganglia of the brain. So we're going all the way through the central nervous system and the internucleal neurons, and now we're involving the basal ganglia of the brain. Now, Hebb's rule is basically kind of a restatement of the law of facilitation. When an impulse has passed once through a certain set of neurons, known as the facilitated section, to the exclusion of others, it will tend to take the same course on a future occasion. Each time that impulse traverses its path, and on all future occasions, the resistance will be less. So basically, you get used to firing in this pattern, and this becomes a brain memory, and it gets used to it, just like any other habit. Spinal facilitation does occur and can be seen following musculoskeletal injuries. And it involves central sensitization within the spinal cord. This sensitization means the threshold of different neurons is reduced, so they respond to mechanical stimuli to which they were impervious before injury. Now, when it does this, something that would normally just register as a touch now is a painful touch. So a hyperstimulated nerve, no matter what its function, can turn into a painful responsive nerve. This sensitization means that the threshold of different neurons is reduced so they respond to mechanical stimuli to which they are impervious before the injury. This process tends to spread laterally in the spinal cord, but in a selective way, and not all neurons are sensitized. For example, the lateral sensitization has been shown to spread to the motoneurons, which supply the muscles in the affected area. So, this bad memory of an injury that happened long ago affects the muscles, just as we said before. This could alter sympathetic activity to the sympathetic sweat glands. So we're involving the sympathetic nerves, which are a lot responsible for pain, and it will involve sweat glands. Now, curiously enough, in hand acupuncture, there is a point right in the middle of the palm of the hand. It is for hyperhidrosis and polyhidrosis. Now, I use this a lot with acupuncture. I never could get it to work too good. And so I thought, well, I wonder what would happen if I would tap it with this small ball tip. And so I started doing that and tending to go outside the box, which I encourage you to do. Think outside the box you've been put in. All of us have been taught things, and we tend to take that in and make it a part of our thinking and belief system, even though it may not exactly be true or true at all. So I started to go outside the box, and I found that for a radius of about 3/4 of an inch outside that midpoint, when it's active, usually that whole circle is. And so you tap just a little bit deeper than the skin resistance on both sides. Then you have the patient stretch for 20 seconds. You perforated the scar tissue. The stretching separates the scar tissue. And that takes the compression off the blood vessels, lymphatic vessels, nerves, muscles, skin, etc. Then you come back on it, and now most of the pain is gone, if not all gone. If you have especially sensitive areas, and again, this does not mean just sore or tender areas, but especially sensitive, second time you just press until the tissue resistance stops you. If it doesn't start to go away within 10 seconds or it flip-flops, then you get off of it for about 20 seconds or 30 seconds. If it does start to go away, then you just hold it until it goes away. After the 20 or 30 seconds, you get back on it, and then it will be gone, or it will start to go away normally after that period of time. Now, the wonderful thing about the polyhidrosis and hyperhidrosis, people with sweaty palms immediately stop sweating. People with sweaty feet stop sweating. People with sweaty underarms stop sweating. I've had people within just a few minutes after doing this, immediately they've stopped sweating. Most of the time it doesn't take more than one treatment to accomplish this. So I would urge you to do this on people with sweaty palms, sweaty feet, sweaty underarms. You will be quite amazed at the dramatic results that happen very quickly, usually within minutes after you do it. Now, all these changes respond to pressure. They show changes in skin conductivity, and they show variability of vasomotor tone. All these things that I'm reading out of are in your notes, and they show all the references. So I would urge you to go through all those references to see where they're coming from. And Structure and Function of the Musculoskeletal System, second edition by James Watkins, 2010. Proprioceptors in the skin are similar to those found in the joint capsules, but there are few in the skin compared with the number in joint capsules. Now listen to this. This 2010. Tension in skin can be caused by movement in a number of directions, and proprioceptors may make a significant contribution to joint stabilization in the reflexive muscular activity. So basically, when you're using this, you're stabilizing the muscles and stabilizing the joints. Just the opposite of what chiropractic taught us. So you're going to see your results amplified because now you're seeing other things that affect the joint. Now we already talked about Ruffini. Now other skin proprioceptors include Meissner's that are located superficially in the skin, and guess what? They respond rapidly to transient movements of the skin. The same type of thing, same type of stretch and myotatic reflex, only these are superficial. Ruffini was deep. And then we have Pacinian corpuscles. They're in the subdermal layer, so they're right between Meissner's and Ruffini's. So the Pacinian corpuscles respond quickly to high-frequency transient movements of the skin. So all of these respond to quick transient movements of the skin, which you get by tapping or swiping and eliciting a myotatic or stretch reflex. And guess what? It's believed that these mechanoreceptors connect to the cortex and modify the activities of the limbs. Joint and skin receptors also facilitate the vestibular apparatus to stabilize the extremities during gait. So basically you're modifying the activity of the limbs, you're changing gait by stimulating the necessary muscles to contract more forcefully and efficiently. This is 2010. It's backing up a lot older type of references. And you're using, guess what, the stretch reflex by tapping or swiping to affect the deep Ruffini corpuscles, the intermediate Pacinian corpuscles, and the superficial Meissner corpuscles that stabilize the joints and regulate the muscles which then regulate the joint angulation. And get this, skin proprioceptors identify environmental changes and provide information about your body's postural alignment. So correcting these skin proprioceptors will correct posture alignment, postural alignment. So this affects a number of things. Here again on Ruffini corpuscles in skin are considered to be skin stretch sensitive receptors of the discriminative touch system. They also work with the proprioceptors in joints and muscles to indicate the position and movement of body parts. Wow, how about that? One other thing on the hyperhidrosis and polyhidrosis area here is since it regulates the moisture in the skin, you can also use these same points to correct dry skin anywhere in the body. So keep that in mind as well. Now in Guyton's it talks about many types of reflexes. Somatosomatic, somatovisceral, somatocutaneal, viscerovisceral, viscerosomatic, viscerocutaneal, cutaneosomatic, cutaneovisceral, and cutaneocutaneal. In Dorland's Medical Dictionary, neurotony, the stretching of a nerve chiefly to relieve pain, also called nerve stretching. That's basically what we've been talking about because we're using the small tip prod to stretch painful nerves and then it relieves it. So it's basically the same thing restated with a different name, only out of Dorland's Medical Dictionary. Now, how did I discover TTAPS? We're going to get into that. Now, I had a knee problem so severe that every time I stood up, I felt my knee shift and it felt like somebody shoved a white-hot dagger into my knee and twisted it. It was super painful. I'd have to stand there several seconds just get over the pain before I could walk. It was so bad that I had to step up with my right leg and then drag my left leg up steps because I could not lift the leg and press up because of the pain. And it was that way for 4 years. And I did everything I knew how. And I went to several friend chiropractors, physical therapists, occupational therapists, and nothing improved it. And so I have an osteopath friend that does a lot of prolotherapy, also called sclerotherapy, where they inject glucose solutions into a joint where you have loose ligaments and tendons, and it causes a little bit of scar tissue to form to tighten the joint up. So I thought, well, maybe that's it. So I called him and I said, George, I need you to look at me. I'm having problems with my knee. And he said, okay, come on over. So I went over and described the problem to him. And so he examined me. And I said, okay, how many injections am I going to need? And he said, none. I said, none? He says, yeah, you're getting old, get used to it. I'm going, that is not what I wanted to hear. So one weekend I was sitting at home by myself in the living room, and wife and kids were gone, and I was sitting there feeling sorry for myself. TV wasn't even on. And I was kind of feeling around. For some reason, my fingers kind of went down here, and right in the meaty body of stomach 36 in acupuncture. And I noticed all the skin around it moved, but that area right there, about a dime around, did not move at all when I tried to move it. So I grabbed the skin and jerked it around, and it wasn't painful at all. I thought, well, that was really weird. It only took a few seconds to loosen it up, and I stood up, and my knee didn't shift, and there was no pain. Unbelieving, I stood up and sat down about a dozen times, and there was still no pain. I walked over to a staircase, and we had a big winding staircase, and I went foot after foot and didn't have to drag a leg, and there was no pain. I went down the steps. Then I went up 2 at a time and down 2 at a time, and there was no pain. Then I ran up 2 at a time, down 2 at a time, and I was astonished. I did almost nothing to something I had suffered greatly with for 4 years, and the pain was gone and the disability was gone. And I thought, what in the heck did I do? So over a period of time, I started writing down several different situations where I barely touched a patient because they were in so much pain, and instantly, without doing hardly anything, they had a big change in their pain. And so I wrote all these down, and I remember back to the first patient that this happened on. When I was in chiropractic college, we had a very interesting family live next door, and I ended up taking care of all of them. But I'm going to show you what I did on this particular gentleman. Now in chiropractic college, we had a 13-year-old boy, I'm going to call Gorilla Boy just because of how he was formed. And Christian here can't even start to do what he was doing because his arms were rotated so far that his palms were forward on both sides, and his feet were rotated so much that the balls of his feet were behind the heels. So if you push him to the side on skates, he would go in a backward circle. Now, I'd just gone to a Van Rump seminar, and I came back, and I thought, well, if I adjust his ribs as they attach to the sternum, his rib cartilages, and the ribs as they attach to the cartilage through here, then that ought to help this. So I did a thumb toggle on these on both sides, and he stood up and his arms rotated normally. But by the time he got back home, he was just the same way that he was. So it didn't last very long at all. And so we did that on 4 or 5 visits, and it didn't stick. So I thought, well, maybe if I adjust the ribs in toward the spine on the back, then that would take care of it to some degree also. So I toggled the ribs and rib cartilages out here and in on the back side, and he stood up and his arms rotated out, and he stayed stood up, but his feet were still rotated out. So he goes home walking like Charlie Chaplin, the only way that he could. And his mom saw him standing erect, and she said, "You look funny. You know, what's happened?" And he said, "Well, I saw Dr. Bonebreak, and he adjusted me." And she said, never having seen her son stand up erect before, she said, maybe you shouldn't go back to him. So that's the response, because she was looking at her loving child that she had never seen in a normal position before. And I talked with her parents about his legs being rotated. They said that it had been recommended when he was an infant to put his legs in braces to correct that. They regretted that they never had. So what I did from the hips was I adjusted the greater trochanters forward with thumb toggle just the same way. And each time I did it, the feet rotated slightly forward. But it rotated slightly forward, and then he'd feel a really sharp pain in both hips because they had never rotated before. So we waited till the pain went away, which would be several days. And then we did it again, and then his feet would rotate a little more, and he'd get the same sharp pain. In about a month and a half, his feet were straight, and he was standing erect, and he stayed that way. And you learn exactly how we did that in part 3. So basically using very little force at all, that occurred. Turn around. Now, I think one of the things that happened with the shoulders here, I don't know that it's so much that I adjusted the ribs, but there's something called an interscapular reflex. And basically the interscapular reflex activates the rhomboids and pulls the shoulder blades together. There's another reflex back here called the infraspinatus reflex. And basically that's right where the spine of the scapula and the inner border of the scapula come together, and it causes arm extension and external rotation. And I think I probably accidentally stimulated those reflexes, but it corrected this gentleman, and it was quite astounding, and I always kept that in my memory. And Dorland's Medical Dictionary says a phenomena is any sign or objective symptom or any observable occurrence or fact. So basically we are looking at phenomena as we're doing this. Break phenomena, the tendency of a muscle to maintain itself in its normal resting position. So we're attempting to restore normal tone to restore muscle to its normal resting position. Also in Dorland's Medical Dictionary, you have the Arndt-Schultz law of hormesis, which is used in acupuncture and homeopathy. The first part of it is weak stimuli excite physiologic activity, which is what we're using a lot of in this particular part of TTAPS. Number 2, moderately strong ones favor it. Number 3, strong ones retard it. Number 4, very strong ones arrest or abolish it. Heretofore, we've probably been using anywhere from 2 to 4, but here we're learning to use the first one. So very light touch, very light pressure. A lot easier on you, a lot easier on the patient. And it doesn't take time, and it gets very quick results. Now, I would urge you to use all the normal orthopedic and neurologic exams that you learned in chiropractic college, and always do a before and after. One of the things that happens, one of the reasons that we lose patients is not because we don't get results, but because they get better. And they call back and they said, well, it got better on its own. So basically you want to demonstrate before and immediately after so they can see that what you just did got the response, and there can be no denying it. And this is what gets a jaw-dropping response from the patient, because they see and they feel an immediate difference after you do this. For example, you might do a pinwheel or vibration sense, like posterior columns, for example. And immediately after you do the poop arch ligament, which we're about to do, you go right back and you do the pinwheel, and it's corrected substantially or altogether, and the vibration sense is immediately better. And they will have said, wow, I can't believe the change that just occurred. And the total treatment, tenths of a second. Now I would urge you to have the patient stand up, not only redo a test, but have them stand up and say, how do you feel different? And they have major symptoms. And you ask them, well, how's this now? How's that? How's the headache? How's the neck pain, the back pain, shoulder pain? How's your carpal tunnel? You'll be astounded at how just doing the poop arch ligament treatment, also called the ilioinguinal or inguinal ligament, all the same structure, gets magnificent results all through the body and very quickly. And because of that, and we'll be showing you the science behind it, we urge you to do that on a patient no matter what the symptoms are, because it may correct symptoms that nothing else is responding to. So do it first, and it gets wide-ranging results very quickly in most cases. So we're going to show you the poop arch ligament treatment now. I became a certified NEMO receptor tonus trigger point therapy instructor. And I noticed that when I worked on the psoas and iliacus that it affected the rotation of the legs. And when I started experimenting with TTAPS, I thought, well, I wonder if I could just tap it and not inflict near as much pain, if any pain, to cause this rotation to occur. I found, to my great joy and the joy of the patients, that it did work that way. So, to demonstrate where poop arch or the inguinal or ilioinguinal ligament is, you just bend the thigh up like this, and it's right in the crease here. And it runs between the anterior superior iliac spine, the ASIS, and the pubic bone. So it's right in that crease. And basically you tell the patient, I'm going to be using some reflexes to make some changes. Is that all right? The patient says, well, yeah, go ahead. So basically, like, rotate the feet out, and in this subject, the right foot rotates further than the left. So you have the patient look at it and acknowledge it. See that? See how this one turns a lot further than that? Okay, lay your head down. Now you hold the area that's not rotating properly at full rotation, and then you go up and tap and say, I'm going to tap right here. Is that okay? Just tap firmly but lightly, and immediately both feet rotate the same, and have the patient look at it again to acknowledge it. Isn't that crazy?
What? Okay.
And everybody gives that same response. They can't believe that just happened. Then you turn the feet in. Now this foot turns a lot further than that one. Have the patient look at it again.
Okay.
And again, you hold it into the restriction. You're basically telling the brain, we need to correct this. And you're tapping the opposite side poop arch ligament whenever you do these. So I'm going to hold it there and tap it 3 times. You release it, let it reset, and then you return it. Now have the patient look again. And you get the same response. And the people looking on can't believe it either. Most of the time, after I do the initial orthopedic neurologic exam, this is the only treatment that I do, because this gets amazing changes. I had a patient that had really bad upper trapezius pain, migraine headache, carpal tunnel with extreme pain and numbness and tingling in both hands. I did this on him, had him sit up, and immediately everything was corrected without doing anything else. So, because of all the changes that can occur, and we'll talk about that in just a little bit, just by working on the hips, then always start with Coupert's ligament, just like this. Now, in the literature, in Dorland's Medical Dictionary, 25th edition, illustrated text, Geigel's reflex, obliquus reflex, and suprapubic reflex all are reflexes around Coupert's ligaments, and I think that's some of what's going on here. Now on top of that, for the hip, I want to bring the leg up, and for example, this is locking right here, and the patient recognizes that. And this subject has maybe 80% or so on this side, 75%, about 10 degrees less on the other side. So now we're going to do some hip rotations. Now, how I came across these was I had about a dozen patients come in that all had really bad sciatic neuralgia, and nothing I was doing worked on them. So I pondered it, and I thought, you know, we learned something about resetting a dislocated hip in infants, and that's Ortolani's maneuver. So I did that on the patients, several of them, and got some limited results. Then I had another thought. Barlow's maneuver slightly dislocates the hip from the socket. So I thought, well, I wonder if that helps. And that helped to a certain degree. Then I played around with which one to do first, and turns out in my experience that doing Barlow's maneuver first seems to get the best response, and Ortolani's afterwards. So basically what you do is you loosen the pants up, and you have the patients hold their hands up in the chest like this, and right here you get a stopping. You're pushing until it just comes to a dead stop, and you ask the patient, is that as far as it goes? And then you see this gap in here, and you get the patient to acknowledge that gap. You see that? So you keep that headward pressure, and you don't have to push a lot, but you're going to keep that pressure all the way around inside, and this is Barlow's maneuver. So you keep the pressure on, not a great deal, but you want it at a dead stop all the way around. And a lot of times you'll get a gratuitous adjusting of the knee while you're doing this. And you go right back up, and you notice that the range of motion has dramatically improved immediately. And the patient is stunned, and you're stunned. That's the neat thing about this. It's always jaw-dropping results immediately. And now this time we're going to do Ortolani's. We're keeping that headward pressure and keeping the pressure all the way around this way. Now we bring it back in, and we have even more range of motion. Now we take the leg up, and we're going straight up. And that should be at least there. Now remember, we started here, and now it's easily going to the straight up position. So you would do that on both sides. Now, when you do that, in the 5th edition of Guyton's, which is in your notes, it states that man is in an upright position. And when he's in the upright position, unlike other animals, the weight rests on the hip sockets. And therefore, when it does that, there's almost no muscular action to keep the animal in the upright position. So basically, when the hip is not in the socket properly, and then all the muscles are trying to tense in some way to keep the body in the upright position. So when we reset it in the hip socket, then the patient will stand up, and now they're not using the muscles. So a lot of the muscle tension in the whole body just goes away, not just the sciatic neuralgia, but everything that is participating in posture goes away. Because now hardly any muscular action is needed, according to Guyton's 5th edition. Now in this posture, we're going to twist the patient, and we're going to hold them in that twisted position right at the end of the range of motion. We're going to make an X over both hip sockets, dragging it both ways. So in very quick motion, drag, 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 drag. You don't have to hold it down very much. It's basically about like brushing dandruff off, maybe just a little bit deeper than that. You just want a little bit of drag on the skin. And you're going to hold them in the other way. Drag, 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 drag. So each way that you're twisting, you make an X over both hip sockets. Now you have the patient lay on the back again. So after you've done Poupart's and then Barlow's and Ortolani's maneuver, then you do this one if you have anything left. And now the patient has even better range of motion. Notice this patient has gotten another 20 degrees range of motion just with the drag on the hip sockets. And it's quite amazing and can make a huge difference in the tension that the patient is feeling in the hips, and all the muscles that are attached around the hip socket will be affected by this. Okay, now we're going to discuss how to restore motion and flexibility to the joints of the neck using the stretch reflex, the myotatic reflex. Here we're going to do rotation first, and it's usually easiest to get around to the front of the patient on this particular part. Now rotation, 85% of the rotation comes from the upper cervical area. So you're going to take your 3 middle fingers, basically, you're going to go from ear to ear, you're going to swipe it. Just remember to look at it like brushing dandruff. It has to be very quick for it to be efficient, and you have to hold it at the end of the range of motion. Now before you do this, you're going to point out to the patient, you notice that your nose points out here, it should be around over here. You get them to acknowledge that. So you keep the neck erect and you swipe just very quickly, just like that, ear to ear. You reset it and immediately take it around, and they've gained an extra 10 to 20 degrees. I've had people that had no rotation and all of a sudden they had 90 degrees rotation. Now, if it doesn't go all the way, you may want to go to the upper front of the neck. And to do that, it's easiest to go around to the front. Now you're going to hook your 3 fingers around the thyroid cartilage and go to the side of the neck on the opposite side, and you're going to swipe around the other half of the neck. You already did the back half, now you're doing the front. So you're going to swipe very quickly, just like that. And that will complete the range of motion. Now sometimes that extra 15 degrees, you're going to need to swipe the lower part of the neck on the back and the lower part on the front. So you do the same thing. Now you're swiping in the direction that you're turning. So looking down from the top of the head, if you're going in a clockwise fashion, you're going to swipe in a clockwise fashion. So down at the bottom, you would do the same. If you had to go to the front on the bottom, you would do the same, only just like that. And you always point out the difference before and after to the patient. I did this, first class I ever gave on this was in Denver, Colorado. And Dr. Williams from the area, he called me up a week later and he said, "Can I go to the next class in Colorado Springs," which was a week later. And I said, "Well, sure." So he came and we got to this part of the class. And he said that he had inherited a woman who had been going to the previous doctor that he bought the practice from 45 years earlier. That doctor had programmed her to come in once a month, and he never had to set an appointment for her. And he let her go after that first treatment, and he said that she had never been able to turn her nose more than maybe 5 or 10 degrees to either side during that whole time he had treated her. She calls up the next day and said, "Can I come in again today?" And he was just astounded because she had never called up to come in more than once a month. So he said, yeah, come on in. So she comes in, she said, I don't know what you did. And she turned her head fully to either side and said, but do it again. So she had gone from about a 5 to 10 degree rotation to 90 degrees, both directions, just by doing the procedure that I just showed you. And who knows how long before he got her that she couldn't do that. And yet it just took one treatment, 45 years of disability gone. Now, the next couple of moves, you're tilting the head to one side, you're tilting the head to the other side. Now, one principle I want you to get a hold of is just like tetanizing current, sometimes you have to help the person complete a contraction so it will then relax. I found that usually it's best to do that first because that usually gets the best results. So, for example, if he tilts his head here and it's not going all the way tilting to the side, that's because the muscles on the other side are not releasing. So you would approximate contraction here. You're going to tap the lateral flexors, so basically about half around the neck and the upper trapezius that goes to the clavicle and back to the spine of the scapula. So you completed the contraction and then it relaxes and it immediately goes 10 to 20 degrees further. Now, we had a gentleman in Denver that we did this on. He had no lateral flexion to one side. We did this, just immediately all the motion was there. And it was astounding. It's like, oh my gosh. I mean, I get astounded with results from this quite often when I think, well, this is going to take more than one treatment. And a lot of times it doesn't at all. And that's how powerful these treatments are. Now, another thing is you ought to be able to tuck your chin all the way to the sternum. And if it doesn't go, then that means the muscles on the back side are not releasing. So in that case, you would tap from the upper neck all the way down to the lower part of the shoulder blades because there are muscle insertions that are fighting that forward flexion. So you ought to be able to go and touch the chin to the sternum. And we had in one seminar a doctor that I put all 5 fingers under the chin, could barely tuck the chin at all, and that was it. And right after we did it, she went all the way down and touched the chin to the sternum. We had to take this muscle into a contracted state and tap it to get it to complete the contraction so it will then relax. Now, so when you come back, you ought to be able to get into a position to where when you're seated up straight, you're looking straight up, just like this. So you don't want the patient hunching over, and hunch over a bit here. Because when they hunch over, then that's going to limit the amount they can take it back. So you have to have them sit up to do this. So if that doesn't release all the way, that means that the muscles on the front of the neck aren't releasing. So you take them into contraction and you tap them. They complete the contraction, then they relax, and you're showing the patient the before and after. A lot of people, they'll lift their neck about like this, and you say, okay, you see that's about as far as you can, that's about the angle that you can look at. Well, we want to have you looking straight up, and then you do this, and immediately it changes, and they're just totally astounded, and they say, my gosh, I haven't been able to do that in decades. And you can imagine how this is causing recurrent subluxations and recurrent trigger points. And basically we're using these reflexes in the skin to affect the joints and affect the muscles around the joints in order to get that to correct. Now the next area is the middle back area. And we're going to do this a little bit different from the cervical area. You have the patient hold the arms like so, straight across, not on the hands on top of the shoulders, and they're sitting erect. So you have the patient rotate, and they may get a limited rotation, like about right here. Well, you point out to the patient, see how you're angled like this? We want to see about a 90-degree angle. You get them to say, yeah, I feel that stopping. So what you're going to do is you're going to take the palm of your hand at the top of one shoulder and swipe down to the lower ribs on the opposite side and back. Now notice you're not just swiping one way, so you're going to go quick, just like this, and you're going to make an X on that. So you're making an X, you're going to drag it both ways. And you reset, and then the patient immediately can rotate better. And you do that both directions, just the same as you do the neck in both directions, in both sides. Then you go down to the lower back. You're rotating, the patient's stuck, you point out to where they're not rotating. Now you're going to go from the lower ribs on one side to the upper iliac crest on the other side. So you're going to swipe both directions and make an X, like that. And you reset, then you twist, and immediately you have better rotation. And you do it both directions. Now, you want a very quick swipe. Again, this is just like brushing dandruff. You don't have to hold a hard contact. It's not a rub, and it's not slow like this. It's a very quick motion. That's where you get the best response. Now, the next one is the sacroiliac. So now you show them the before, and you swipe across the upper iliac crest on one side to the lower outer butt cheek on the other one. So you're swiping both ways, and then you make an X. You reset it, and you rotate, and you're pointing out to the patient. Now, this is going to take care of chronic middle back pain, chronic low back pain, chronic sacroiliac type of pain, just by doing those moves. And it's quite jaw-dropping how quickly the movement comes back, and how much easier it helps for the adjustment to happen, because you're relieving all that muscle tension. And again, you're getting rid of trigger points that are being controlled by Meissner's and Ruffinian and Pacinian corpuscles in the skin, controlling the joints, controlling the muscles surrounding the joints. So this is just very in your face how good this is and how quick it occurs. Now turn around. Now when you swipe the front of the throat, you're going to notice that the thyroid, the parathyroid, the larynx, and the pharynx are right there. And when you do the swiping here, all of a sudden their thyroid is working better. Their parathyroid is working better. Their speech, their singing is much fuller because you've released all those muscles in there. And it's quite in your face. Now, some people have trouble with chest pain. They have trouble breathing in deeply. So in this case, you have them hold the arms like this. You twist them. You're going to make an X. Again, swiping both directions on the axillary area. So it's very quick. And you go to the other side, making an X. And you're going to go from the upper chest to the lower chest wall on the other side, like this. You're not touching the breast area, so don't be really concerned about that, although you may want an escort in the room. But always explain to them beforehand. And you twist the other way. You're telling them this releases these muscles, the breathing muscles, between the ribs, just the same as we did in the back for your spine. And they get it. And you notice I'm not taking any time to do this. And immediately they can take a deeper breath, and it's quite astounding. At the same time also, you have abdominal issues. Now before you do this one, you have the patient lay on their back and you compress the abdomen, and you're going to have all sorts of painful areas when you press on it. You do the same thing. You have them hold the arms up, you twist, and you go to the side of the abdomen, making an X, front of the abdomen, side of the abdomen, and then you go to the other direction. Just that quick. You notice I'm not dragging hard, I'm being very quick. I'm dragging both directions and making an X. So you don't just drag one way, you drag then you make an X. Now when you do this, right afterwards you press on those areas of the abdomen, and amazingly a lot of the pain will be gone just from doing this. You may have some residual pain, let's say over the bladder or over the uterus or ovaries. We'll just do it just on that area, sweeping that way. And it's just amazing and in your face how quickly the pain dissipates just when you do this. Now I had a gentleman that after I worked on his knees and his back, I said, okay, let's sit up, and he said, I can't. I have to roll on my side. So rolled on his side and we sat him up, and I said, why can't you? And he said, well, I've had 4 surgeries where the cut was under the ribs. So I was flapped open 4 times. After the first time, I couldn't sit up under my own power, and they said I'd never be able to again. I said, really? So I said, let's try something. And we did this on his abdomen, both ways, just as I just described. I had him lay on his back, and he sat up by himself. He was told that he never could do it again, and those simple swipes corrected that. The swipes on the chest, in the chest wall, they will correct all sorts of pain. You'll have sidewall pain, you'll have pleuritis, you'll have asthma, you'll have emphysema, you'll have bronchitis. This can correct totally some of those, and at least correct them to a big degree just by doing those swipes. And turn around again. Now this can be spliced in after this part. Okay. Now we did each of these parts, just to demonstrate that each one respectively got great results. But in essence, when I'm in my office, I do the neck, and when I twist, I will do the middle back, the low back, and the sacroiliac all in one swipe. And I won't do them individually. I'll just do them all at once. And it's very much quicker that way to do it that way. Now go ahead and stand up. Now someone who can't bend to the side, you have them bend to the side and the same thing applies. If they can't bend this way and you have their hand down here on their legs, then that means that these muscles aren't releasing. So you take them back in this position, you tap and you swipe, then they release. Now you can bend a lot further to the side. So apply those principles in all of those areas. Now the first time that I did the middle back on anyone, it was a 21-year-old female who had had fibromyalgia for 4 years, and she hurt all over. And so always ask the question, where do you hurt the most? I'll say especially in fibromyalgia cases. So she said between the shoulder blades. So I just had her twist, and I didn't get this down to what I have right now. So I just kind of brushed between the shoulder blades like this, twisting both ways, and I said, stand up. She stood up and she said, now what? And I said, how's the pain? Her jaw dropped and her eyes went wide open. She said, oh my gosh, that's crazy. I don't have any pain anywhere. So taking care of the biggest area of pain got rid of all the fibromyalgia pain just by sweeping between the shoulder blades. Here we're going to talk about external and internal rotation of the shoulders and the wrists as well. First, take the butt of your hands to the butt of the patient's hands. Not grabbing the fingers, not grabbing the wrist, but butt of hand to butt of hand. Notice I have the index finger running up the wrist, the thumb is grabbing around the wrist, and the outer three fingers around the wrist. Now, you turn outward, and you're looking to see if the patient's hands turn 90 degrees outward. You notice in this case, the left one does, the right one is short. So you hold it at tension, basically telling the brain we need to correct this. You tap the opposite shoulder in the crease of the shoulder by turning the hand outward, and you're going to tap about 15 degrees outward. 1, 2, 3. And it's a tap, it's not a push. You relax the arm and you turn out and the rotation corrects. Now if it doesn't correct all the way, then that means there's tension in the pronators. So to correct that, you turn into pronation and you tap on the pronator teres at the elbow and the pronator quadratus on the palmar or volar side of the wrist. And after you do that, they will then release. What you're doing is you're making them completely contract so that they will then relax. The next movement is to go butt of hand to butt of hand with the patient's palms down. And you turn inward. When you turn inward, the palms should turn straight up. Notice this side again is not turning all the way. So you drop the opposite side, hold this side in tension, again tap in the crease of the shoulder 15 degrees out, let the arm relax, and you turn all the way out again. Now, if it fails to turn all the way in, that means that the supinators are not relaxing. So you hold them in a contracted position, tap so as to make the muscle fully contract so it will then relax. Then you'll find then it will release and your hand will go into full pronation. Right, this is for carpal, ulnar, radial tunnel syndromes. First we do Phelan's test. Turn toward this camera. And you notice the patient has trouble bringing the wrists together and the elbows are straight across. Now, when they don't come together, then that is one thing for carpal tunnel syndrome. So, what we do, that means that the extensor muscles are too tight and they're not releasing. So we take it into extension, tap the extensors, which cause them to fully contract and then release on both sides, and have them immediately come back together, and now they come together. The second test is reverse Phelan's. They're pushing with the arm straight across, and you're pushing and the wrist can't come together. So that means the wrist flexors are not releasing. Therefore, you correct the flexors by taking it into flexion, tapping the wrist flexors so it will finish the contraction and then release. And immediately come back and the butt of the hand will come together. You'll find that Phelan's, reverse Phelan's, and Tinel's signs will all improve or completely, usually in one treatment, just doing this maneuver. Next, you may have a tethering problem, which may show up as any of the tunnel syndromes. For example, someone may say or have been told that they have carpal tunnel syndrome and they're wearing a brace which relieves it at night. You ask them, where does it hurt? They point at the thenar eminence, which means the opponent's pollicis. So you try and pull the opponent's try and pull the thumb back and you find that it doesn't go very far. It should be way back here, but it goes here. The patient is feeling a lot of discomfort. So you take the thumb into the palm as far as possible and merely tap on the thenar eminence a few times. Immediately release, and it immediately will come back almost to full extension. Same can be done with any of the other fingers, which may show up, for example, as Dupuytren's contracture. So any of these not coming back, especially these three fingers in Dupuytren's contracture, may come from the palmaris longus muscle. Now if you make an X right in the middle of the meaty portion of the forearm, the middle of the palmaris longus muscle is right there. So you have the person bring their fingers and their hand in to make a fist and cock the arm, tap right there, right in the middle of the muscle, then the fingers just pull them back, and they usually will release right away unless there's a significant amount of scar tissue involved. So it comes out very quickly that way. If they're having trouble making a fist, it's basically the same thing. That's because of a problem with the extensor muscles not releasing. So you take it back into extension, tap on the extensor muscles, and all of a sudden they can make a full fist in that manner. If the patient is having trouble separating the fingers like this, it means the muscles are in contracture, the dorsal interosseous muscles between the fingers. So you would have the patient contract the fingers together, tap between the metacarpals on the dorsal interosseous muscles, and the patient will immediately be able to separate the fingers easily. The fingers may be stuck in abduction and can't bring the fingers together. So here you're going to tap on the abductor digiti minimi on the side of the hand, the abductor pollicis, and the tendons that abduct the fingers right by the base of the fingers. Right after you do that, the fingers will be able to be brought together. So basically have them hold it as far of abduction as possible, tap on the muscles and the tendons, then they'll be able to close them together. Here the arm is failing to extend properly, meaning that the flexors are failing to release. So you take the arm into flexion and you tap on the biceps and brachialis and on the brachioradialis in an approximation of contraction. And then they release and the arm goes straight. Now another way to affect bicep contraction may not go all the way from tapping the biceps. So such as in a stroke, you're going to put a light tension on the biceps and tap the triceps to cause reciprocal inhibition, and the biceps immediately releases. Here we have hand clench such as in stroke or cerebral palsy. You have to get on the tips and put a light traction on, take a small tip prod and tap it right in the middle of the palm of the hand. The fingers will open, just like that. Here we're looking at the elbow rotating externally with the arm straight out to the side. Here we have a subject where the wrist is not going significantly behind the elbow, in fact not at all. So we reach down the chest to just above the nipple line on the pectorals We swipe very quickly down to the base of the shoulder blade, then over the body of the deltoid, then over the deltoid insertion. Then we let it reset, and you can pull the wrist easily behind the elbow. Next, we're looking at internal rotation. Should be able to internally rotate with the wrist going behind the elbow. Now, you're going to, in both occasions, swipe with the direction that you want to go. So here, you're swiping from the base of the scapula very quickly to just above nipple level on the front, in the deltoid and the deltoid insertion, while you're holding the tension in. Then you let it reset, and it easily goes behind the elbow. Here we have a subject, we're trying to pull the elbow across the body. Here it's not going past the throat, it's going to the side of the throat. However, on the other side, it's going all the way across. Now the dichotomy here is the 50-50 rule of acupuncture. That is, you treat the opposite side. 50% of the time you treat the opposite side to the symptoms to get the curative effect. So here we're tapping the good side down the pectorals and the anterior deltoid and the biceps. Then that corrects the side that was bad. Now if tapping doesn't get the full effect, then we swipe the skin across the latissimus dorsi and the triceps on the good side to help get the full effect. Now sometimes when the tapping doesn't get it, you need to also swipe in the direction you want it to go from the back side. So here we're swiping very quickly across the latissimus dorsi and the posterior deltoids and the triceps. So very quickly, just like that. And that gets the effect that you want. Here the subject is we're trying to get him into a hammerlock position where the fingers can touch. On this side, it can't. On the other side, it can. So we treat the good side in the direction that it's going. So for example, just like this, the bad side we treat, or the other side we treat in the way it's going also. After that we come back to the bad side. Now we get a great or total correction. Now the patient is having trouble touching the arms and back with the hands supinated. So we need to complete the contraction in the front, both by tapping on the anterior deltoids and the pectorals and the biceps, and sweeping forward from the back to complete the contraction, so it will then relax and touch in the back. Person with rotator cuff syndrome, frozen shoulder, adhesive capsulitis. Usually this next maneuver will get it. You have them clasp the fingers, fully extend down, come up to the front, and if they're having a hard time, then they're going to start griping right here. So you have them duck the head, pull the head back, and then you squeeze the shoulder blades together 5 times, as hard as possible. And you take the hands out from behind the head and pull into the side. Now if they have a lot of problems, they're going to be griping they can't do it right here. You say, do you want to get better? Pull it in, pull it in, pull it in, pull it in. And then finally get it in. You do each side 3 times. Again, they're going to be having trouble with that. Then immediately after that, they were having trouble putting their hands behind their head. Now they can gap it. So you have them gap it 5 times or so. Then put the hands, palms up above the head, and rock the shoulders side to side and sweep down in the front. If that doesn't fully get it, you grab the wrist of the affected side, the bad shoulder, pull it behind the head, you sweep the upper arm right into the body, not out here at the end. You keep it in and you sweep around 3 times. Usually just doing the very first one does the trick. Sometimes you got to do the second one. Very occasionally you have to send them home and do it at home on a repeated basis. What I think is going on is you have dense scar tissue that's binding the supraspinatus tendon going through the canal formed by the scapula. And I think this is just breaking that scar tissue and popping it through. Now the body doesn't have to protect that tendon, protect that joint, and it gives it back free range of motion. Now basically before this, you tell them to raise the elbow above the shoulder and they can't because of the pain and restriction, so the elbow won't go above the shoulder. It's called hunching. You have them take the hand behind the back, they can't, or they barely can because of the pain. Immediately after these mobilizations, manipulations, have much freer range of motion because you've freed that supraspinatus tendon. And now they have a better free range of motion and the pain immediately goes down. For internal organ manipulation, the law of average localization states that visceral pain is most accurately localized in the least mobile viscera and least accurately in the most mobile. Therefore, you have adherence of your internal organs to each other, to the capsule that they're in, to the muscles that they're laying on, the bones that they're near. So basically, when there's adherence, scar tissue causes a problem with lymphatic drainage, blood vascular circulation, muscle or nerve impingement, muscle function. This affects secretion, excretion, all the functions of the internal organs, and can cause a backup of lymphatic fluid, for example, in the abdomen, causing ascites. So what you want to do is spread your fingers, and you're going to make using the navel, a plus and a times. You're going to spread your fingers out and take a detention just like you would a vertebral subluxation to correct it. Angle down roughly about 15 degrees, take detention, give a thrust, very light thrust. So we spread the fingers to get as broad a contact as possible, angle it down 15 degrees, take the tension just like a vertebra, and give a thrust or an impulse. About every 2 inches, do it again. You're going to go around the clock. So you're getting the whole abdomen. You'll find it frees up a lot of organ function and helps drain the excess fluid out of the abdomen, as well as some out of the lower extremities, and the patient really responds well to this. Let's talk about cranial nerves. First is cranial nerve 1, olfactory. This is out of the embryology, development, and anatomy of the nose, paranasal sinuses, nasolacrimal passageways, and olfactory organ in man by Schaefer in 1920. It states that a few afferent sympathetic neurons are apparently located in the extracentrally placed sympathetic ganglia. Now, I didn't know before I read this that sympathetic nerves had afferent fibers. I thought it was only efferent. Also says that you can have reflex nasal manifestations of the respiratory tract, sneezing, coughing, and asthma directly traceable to nasal disorders. Migraines and neuralgias may be manifestations. Gastralgia, indigestion, and vomiting. Alteration of the cardiac rhythm, numerous sexual phenomena. This is all coming out of the nose. Also have nasosexual relations, and one of which is priapism, for example, which is persistent abnormal erection of the penis. So basically, when you're correcting these reflexes, you restore to normal. So if you have erectile dysfunction, it can correct the erectile dysfunction from the nose. Dr. Fleiss in 1895 and 1897, and we'll talk about later, discovered genital spots. And in the inferior turbinates, he found an area that when he applied cocaine to it, then the menstrual symptoms went away. Subsequently, others found that the inferior nasal turbinates affected the reproductive and urinary tract. In the middle, the digestive tract. In the upper, so Fleiss in 1895, Dr. Fleiss in 1897 called the attention of the medical community to the inferior turbinates. He found that by applying cocaine to a certain spot in the inferior turbinates, he could kill menstrual symptoms. Subsequently, others found that you could control genital urinary areas from the lower turbinates. Later on, the middle turbinates with the digestive system, the upper turbinates with the vital organs, such as heart and lungs, sometimes kidneys. They also found that the second cervical segment could be controlled from there. So if you have somebody who has a chronic second cervical segment, it may be from reflexes from the nose. They also discovered that you could have control of the optic and tactual systems, meaning that visual disturbances and problems with dexterity are controlled from the nose as well. This Introduction to Neurology in Philadelphia in 1916. One other thing is that there is a control of the sense of smell and the sense of taste. So you can control sense of taste and sense of smell and taste from the nose area. And if it's off, then you can correct it, and that will be corrected. Okay, now we're going to focus on the second cranial nerve, the ophthalmic. I had patients coming in who had scotopic vision, meaning that they had trouble walking through a store that had white ceiling, white floors. It's like they were snowblind. And they had to have special lenses, anywhere from $850 to $1,850. Now, the eyes sit on something like a hammock, and it can get caught up and not be able to move and rotate properly on that hammock because of keratinization. And we had we address the reason for the keratinization in part 4, so you may want to take that course for that and many other things related to sight in the eyes. So basically what we discovered was with eyes open and eyes shut, you want to go with the cardinal areas of vision, which is in a plus and in a times. So you're going to have the 3rd and 4th and 6th cranial nerves involved. So first you want to do it with the patient looking to one side with the eyes open, for example. So look to your left and you're going to press in the direction they're looking, and you notice that when you do that you can see and you can feel the eye moving and it bulges on the opposite side. Then you want to have them look down and left. The same thing here. Straight down. Down and right. Straight right. We have a little bit of restriction here, so we take the tension, give it a light tap, and now we have good movement. Now up and right, straight up here, up and left. Next we do it with eyes closed, all the same things. So with eyes closed, look to the left. This is hung up a bit. Down and left, straight down, down and right, straight right. This is hung up a bit. Up and right, straight up, look up all the way, up and left. Just remember, when it's not easy to move, you don't feel it moving, you don't see it moving, and you take the tension with another finger and you give it a light tap, and that gives the excursion. Now after I did this on some people for that, you can immediately have them go to a window and they'll notice immediately that things aren't as bright. And usually they'll go outside and they don't have to wear their sunglasses, for example. These are people who have to wear the sunglasses on a bright day. These are also people who have trouble with headlights and taillights at night. They have trouble with night vision. We found that all these people are reporting back they don't have trouble with night vision anymore, so it's not just a matter of vitamin A. And they don't have trouble with headlights and taillights. They don't have to wear their shades when they go out at night, and they don't have to wear their special lenses because their scotopic vision has improved. One other thing is that afterwards, I've done this at seminars, and one seminar in West Des Moines, Iowa, a doctor sat down. I started to talk again. He said, "Wait a minute, I have to tell the class something." I said, "What's that?" He said, "I just sat down and I'm farsighted and I have to wear reading glasses. I have for years. I put them on and it was blurred. I took them off and now I can see straight without them. Matter of fact, I can see the sign at the back of the room and I couldn't read it before without glasses on." And the 3 women that I just treated right before that said, "We noticed that too. We were talking to each other. We could not read the sign at the back of the room, and after this treatment we could read the sign." So basically, when you think of it, when the eye is having trouble with excursion, all the muscles tense around it and alter the shape of the eye and alter the visual spot. And when it doesn't have trouble moving, then the muscles aren't protecting the eye, so their tone corrects, and now the shape of the eye changes, and people with near and farsightedness notice vastly improved vision. One other thing that people have noticed, I've been getting calls back, is that glaucoma has reduced or gone away, and floaters go away just right away. And if you think of it, the canal of Schlemm, which acts as a valve for the fluid in the eye, when it's partially closed, it doesn't allow the floaters to go out. And when it's closed enough, then it causes a buildup of pressure in the eyes, which is what glaucoma is. So it just makes sense when you correct the tone in that muscle and the valve is working right, then the pressure in the eyeball and the floaters correct, at least to some degree. So these are side effects that I didn't anticipate at all. We had a patient come in that had a stroke 6.5 years before I saw her. Her husband brought her in, and after the stroke her eye deviated to the side, so she had strabismus. And so one of the things that we did for her was to correct that. Hilton's law states that the nerves controlling the joint and the structure surrounding the joint also controls the skin over the joint. So basically what we did is we took and we went right in front of the tragus on the side, which here is right here, just right over the TMJ basically. The tragus is here. And we very quickly swiped up and down about a ½ inch, and we made a plus, sweeping both ways very lightly, and we made a times in order to influence the semicircular canals beneath it. And we did it with both hands simultaneously. Just like that, and immediately the eye uncrossed. Now prior to that, while I was talking with her, she would look at me and look away, look at me and look away, look at me and look away. After I did that, immediately she would look at me and she could concentrate. And the husband was astounded because she hadn't been able to do that for 6.5 years. Later on, I wondered if it might help nystagmus. So we did the cardinal signs of vision for 2nd, 3rd, and 6th cranial nerves, and we found nystagmus in several of them, and we did the same thing, and it corrected the nystagmus just instantly. Now in Dorland's Medical Dictionary, 25th edition, under laws it has Florin's law, F-L-O-U-R-E-N-S. Stimulation of the semicircular canal causes nystagmus in the plane of that canal. So basically, on the basis that you can stimulate a nerve to correct the tone anywhere on the nerve, stimulating that nerve not only would cause nystagmus but would also correct it. And that goes right along with what we found. Now there are other ways to cause the patient's eyes to dilate or constrict, and they may have trouble with night vision or bright vision in the day, or headlights or taillights. And in order to demonstrate this to a patient, I would open the eyes and get close to them in their face, and the ciliospinal reflex says that when you irritate the nerves at the back of the neck, then the pupils dilate, so that they could see that what I was doing had a physiological consequence. Well, the cutaneous pupillary reflex, and all these are found, anytime I say reflex, they're found under Dorland's Illustrated Medical Dictionary, 25th edition, under reflexes. If I say law, it's under law. If I say phenomena, it's under phenomena. So the cutaneous pupillary reflex states that dilatation of the pupil on pinching of the skin of the cheek or the neck. The platysmal reflex says the act of nipping the platysma contracts the pupil. So basically the platysma is on the cheek and goes down the neck and over the clavicle. Basically it's saying the same thing One says it dilates, one says constricts. Basically, it corrects it if it's off. Skin pupillary reflex, dilatation of the pupil produced by irritation of the skin of the neck. So basically what we're looking at is I take the patient and I nip the neck and the cheek all the way down. And then I tell them to do it at home a couple of times a day. Basically what we see again is a correction of a fixed dilation or constriction or trouble being able to fully dilate or constrict upon command by the level of light in the room or on the road or wherever. Correction of the eyes and visual defects has other positive consequences. It affects positively motor coordination, both in the same limb, between limbs, eye-hand, foot-eye coordination. So, for example, when you're correcting the eyes, such as we talked about, you'll have several older individuals who you couldn't recognize their signatures. Now you can recognize their signature, for example. Someone, for example, like a baseball player is having trouble throwing to a base or throwing to the catcher or throwing to the infield. And now all of a sudden they're nailing it. Quarterback is having trouble nailing it on the pitch with the arm or on the pass with the arm. Basketball players have trouble making the baskets or passing, and we see correction with that. Soccer players with foot-eye coordination who are having trouble hitting the goals, who are having trouble passing, now all of a sudden they're able to nail it again. Punters and field goal kickers are able to do it the way that they should now. And any number of things just like that in everyday life. Cranial nerves 5 and 7 concerning the face. There's the corneomandibular reflex. Basically you have the movement of the lower jaw toward the side opposite the eye whose cornea is lightly touched and the mouth being open. So the patient's mouth is open and you have somebody who has trouble with one of the other TMJs. Let's say they have trouble shifting to that direction. Well, you touch the cornea lightly and the jaw shifts and it corrects the TMJ when other things would not do it. Corneomental reflex, unilateral wrinkling of the muscles of the chin when pressure is applied to the cornea. So you apply the cornea here and they wrench and then the face releases and becomes normal. So basically you have an older person whose jaw is wrinkled, and I'm sure you can think of them. Touch the cornea, they grimace, and then the wrinkle goes out. Palm chin reflex. Basically here you have somebody whose chin is twitching side to side. Normally you think of an older individual. This states that twitching of the chin is produced by stimulating or scratching the palm. So basically you can take the small tip prod and go in the palm of the hand, one or both hands, and the twitching will stop. It will normalize the twitching as you're doing it. And you have a patient whose mouth is open all the time. We call them fly catchers. They're walking around with their mouth open. Basically you stroke the chin and the mouth closes and it stays closed. So you may stroke it on both sides and the reaction is the mouth closing and the tone of the mouth normalizing. Chvostek's sign, tapping of the facial muscles over the parotid gland or facial nerve results in spasmodic contraction of the ipsilateral facial muscles. So the patient squeezing on one side and you're tapping over the parotid gland or the facial nerve like this, and they contract more and then it releases and becomes normal. Another one is Bell's palsy. Everything is drooped on this side. You tap there and it cinches up and the Bell's palsy goes away. So it can correct it either way. It normalizes the tone. The glabellar reflex. Lightly tapping the forehead between the eyebrows or the supraorbital ridge with a resultant persistent tonic spasm of the orbicularis oculi muscle with closing of the eyes. So you have somebody who is squinting perpetually, and you tap them here or there and it causes them to grimace and then their eyes open normally. Or you have somebody whose eyes are open very wide, wider than normal, and you do the same thing. You tap and they grimace and then the eyes are normal. Either way, restores the normal tone. Snout reflex. Sharp tapping of the nose or of the middle of the upper lip produces an excessive grimace or an exaggerated reflex contraction of the lips. So just think of Donald Trump, for example, when he was running for office, and you have a grimace and the nose is sticking out, and you tap on the snout or you tap on the upper lip and the face returns to normal. And also say the dirty old man puppet on Jeff Dunham kind of looks like this as well. Facial or bulbomimic reflex. Pressure on the eyeballs causes contraction of the facial muscles of expression on the opposite side to the lesion. So, for example, if there is a spasm on this side, and you press on the eyeball here, it contracts on the opposite side and then relaxes. Or you have a Bell's palsy where it's too relaxed. You press here and it cinches up. It contracts on the opposite side and it normalizes. So that's two ways to take care of Bell's palsy that we've seen here. Cochleopalpable reflex. Contraction of the orbicularis palpebral muscle resulting from a sudden noise produced near the ear. So basically, unexpectedly, you would "oh!" like that, and it would correct the eyes. Percussion above the arcus superciliaris, or the supraorbital nerve, which is about a third of the way over right here, cause contraction of the orbicularis palpebrum with closure of the lids unilaterally or bilaterally. So think of somebody who looks like they're on drugs and the eyelids are sagging, and you tap here and they contract and then the eyelids assume a normal posture. Next is the eighth cranial nerve, the auditory nerve. The audito-oculogyric reflex is the sudden turning of the head and eyes toward an alarming sound. So if you have someone with torticollis, you go to the side opposite where they're looking and can't turn their head, and you make a sudden sound, and they suddenly turn toward it, and that corrects it. Now, I gave this at a seminar, and the doctor said, I had that happen in my office. And I said, okay, tell the class. I had no idea what he was going to say. He said he had a 7-year-old kid, parents brought him in, he had torticollis. While he was standing there trying to figure out what to do because he never helped it before, the shelves with a bunch of books behind him fell down and the kid suddenly jerked his head and it was corrected. And everybody said, did you make him pay for the shelves? So we all had a laugh over that. But the thing is that reflex, and it helps get immediately over torticollis. Auditory reflex. any reflex produced by stimulation of the auditory nerve, especially blinking of the eyes at a sudden unexpected production of sound. So you have somebody who blinks their eyes all the time, just all the time blinking, and ah! And that corrects the blinking, because it corrects it and normalizes it either way. Or you have somebody who's not blinking, that makes them blink at a normal rate. Now the next one is, I had people coming in who asked if I could help correct tinnitus or ringing in the ears. And we've all done the earlobe pull, and we've all hurt some people's earlobes. So I looked around and I said, you know, all you can do with the earlobe pull is pull on the lobe. I said, here's this tragus, and the tragus is here, and you can either push or pull on it and get an effect. So when there's a sudden, very loud, unexpected sound here, it jams the external ear canal in, which the outer third is cartilage and the inner 2/3 is bone, up against the tympanic membrane, and this alters the vibration of the ossicles that contact that. On the other hand, you might stifle a sneeze and push it outwards with something similar happening. So here we can either push or pull. Now, one of the things that we do is we can do a Weber's test, but I do it modified. I tell the patient, I want you to tell me if you hear this at all, or if you hear it equally in both ears, or more to one side than the other. Now, to do this properly, you always test right in front of the nose. You don't test it to one side or the other, because that may bias the test. So, for example, you test it right there, put it on the top of the head. They say, well, it sounds the same, or I don't hear it at all, or it's going more toward this side or that side. Now, what I don't do is, after it fades here, take it over to the ear. I used to do this, and I learned that when they had that and it's lateralizing to one side or the other, I say, you have trouble hearing people, like when you're in a noisy restaurant, don't you, sitting across the table with somebody, and they say, oh yeah. Or when you're talking with somebody and there's a lot of background noise on the phone, they say, oh yeah, absolutely. And having asked that, people would come back after a certain number of visits and they'd say, when are we going to do the tuning fork thing again? And I said, oh, you're hearing people better in a restaurant, right? Oh yeah, absolutely, and better on a phone when there's background noise. Oh, absolutely. So we do it again, and we'd find that the lateralization had stopped or gone down. You may have all 5 of them lateralizing one way or another, but it's improved significantly. And we'd have people who were hearing tones that they couldn't hear before. Now that should have connected with me about true nerve deafness, but I gave a seminar in Omaha, and an older doctor in his 80s said, can you help hearing? I have 2 hearing aids in. I said, I don't know, let's give it a shot. And we did this, and we treated it the way I'm going to show you here. And the next day he came back and he said, I don't need these anymore, I'm hearing perfectly. Came back and gave the next part seminar 6 months later. He said, I still don't need them, my hearing is perfect. I should have put 2 and 2 together when people were not hearing certain tones at all, and then they could hear them. But it took this fellow, demonstrating, saying that he didn't need the hearing aids anymore, to realize that it helped true nerve deafness. Now, one of the things that may happen is there may be significant scar tissue or even calcification where the external ear canal butts up against the tympanic membrane, And I've had people where I've had to treat them several times before they could hear any tone at all. And all of a sudden they start hearing tones, not necessarily. I use 5 tuning forks. They may not hear all of them, but they start to hear again, and it builds up. So just because it doesn't work the first time doesn't mean that it isn't going to work at all. It may take a while to jar that loose. So if you get an abnormal tuning fork, meaning you can't hear the tuning forks, certain of them, or they lateralize instead of hearing them equal on both sides, then you do the following. You take the tragus right at the base where it attaches, and you're going to press in and see if you can feel a restriction or an easy give right at where it attaches to the bone. You have upper, middle, and lower. And if it's restricted, you press and you tap, and then you feel it ease up right there. And you do it pulling out, upper, middle, and lower again. If there's a restriction, then you take the tension with the opposite finger or finger from the opposite hand, give it a couple of taps, and free it up. And then you pull it up, you pull it down. So there's 3: pushing in, upper, middle, lower, pulling out, upper, middle, lower, pulling up, pulling down. You do it on both sides. Then you immediately go back and retest. Again, making sure that you retest, tapping the tuning forks right in front of the nose so that you don't bias the test to one side or another. What normally happens is the ringing in the ears goes down substantially, maybe by half on the first try, or even goes away. And you go back and you redo all the tests. Now they have as many as 8 tuning forks in a packet now. I say the more the better, the more things that you can test. So you're going to have the person hearing tones that they couldn't hear at all before, and a lot or all of the lateralization will go away, demonstrating an immediate improvement. And the patient will be able to tell, because they can tell that the ringing in the ears goes down, and they'll be able to tell that they can hear you better even talking, or light sounds that they couldn't even hear before. Immediately they can hear them better. Guyton's Physiology, 5th edition, stated that the areas of the skin that have the largest density by far of arteriovenosus anastomoses, which helps regulate body heat, are the volar surfaces or palms of the hands and feet, the ears, the nose, and the lips. And therefore they have the largest amount of sympathetic nerves. Now, is it any wonder that there is foot and hand acupuncture and reflexology, nose acupuncture, ear acupuncture, or auriculotherapy? I think not. I had a patient come in and she said, "Can you do anything for my cold hands and feet? I can't get near my husband laying in bed at night because my hands and feet are like ice." And knowing about this, I said, "Yeah, I think we can do something." So I took my small tip prod and I went over the volar surfaces of the hands and feet, and there was no change whatsoever. I thought, well, that threw that out the door. But then she said, "My nose is really cold too." I thought, oh, that's another one of those 5 areas. Now this is important because in the 8th edition of Guyton and Hall, it left 2 of those areas out. Why? I have no idea. Anyway, I went up to the nose and I went over it like I'm about to demonstrate, and immediately within minutes her nose, her hands, and her feet got warmer. I've done this on hundreds and hundreds of people, did it on people at seminars, and it happens very immediately. I had an MD fly into Kansas City from New Mexico. The MD had Raynaud's syndrome, which is really cold hands. Within 10 minutes, the doctor's hands warmed up. Unbelievable. But it's a physiological response utilizing these areas of high density sympathetic nerves. And it seems very consistent that the nose controls the warmth of the hands and feet. Now, you can also use this on individuals, with cold ears, and they have like continually red nose, ears, hands, and feet, meaning they have too much circulation, because it just basically evens them out and it normalizes the sympathetic tone. So what we do is we take the tip of a small ball tip probe, and you cover the eye because you don't want to poke them in the eye, and you just slightly tap, just like this, just as quickly, over the surface of the nose. Some people, all of it is going to be sensitive, but normally right here on the nose, the end point of the large intestine nerves. And you go right along the base, just under the nose, and just inside the nose, maybe 1/4 of an inch. I didn't always do it at the base of the nose, on the bottom, or inside the nose. The reason I started doing that was because in Salt Lake City, a male chiropractor and his father had come to a seminar, brought his wife chiropractor to the next one, and she was having all sorts of problems after, I think, 22 surgeries and 3 children in the abdomen. And we worked on the scar tissue of the surgeries, which we show you how to do in part 2, so don't miss that one. We immediately calmed down the pain from the scars, but she also had cold palms and cold hands and feet. While I was working on the nose, that settled down immediately. However, as I was working on the nose, some women, after they have children, they have the midriff drop, the lower abdomen drops out. It immediately sucked in while I was working on the lower parts of the nostrils, and the pelvic pain that had been there since she had her children went away while she was on the table while I was doing this. And I had thought up to that point that to work on the turbinates, to influence that area, I had to go inside the nostrils. Then I realized that the nerves come out to the nose and just inside the nostrils, and you get a corrective factor there as well. So I was amazed, and I've used it on hundreds of people since then, including at seminars, and get just amazing results with that. In hand acupuncture, right in the middle of the palm, there are polyhydrosis, hyperhidrosis points. Now, I tried to use needle acupuncture on these many times, really didn't get anywhere. So basically, they control sweaty palms, sweaty feet, sweaty underarms. And I decided, after I started using these small tip probes, I thought, I wonder what had happened. Now, I used larger ones, didn't get anywhere. But I got into the very small ball tip probes, and then it started working. So basically, you take the small tip probe and you don't go straight into it. You go kind of like using a pen. And I found, going outside the box, that I found tender points in about a 3/4 of an inch radius around it. So about 1.5 inch diameter right around that middle area. And so basically you poke just a little bit deeper in the skin resistance to break up scar tissue. And you have the patient take the fingers and stretch the area out like so for about 20 to 30 seconds. And Then you have them open the palms again. And you go on the very same points, this time looking for residual points that are especially sensitive. Now I don't really care if they're a little bit tender or sore, but we want something that's especially sensitive. Any of those, this time, instead of pressing a little bit deeper than skin resistance, you're pressing just until the skin stops you. Now if it starts to go away within 10 seconds, you keep holding it until it's pretty much gone away or stops changing. If it doesn't improve in 10 seconds or it just flip-flops, then you get off of it for 20 or 30 and go find others elsewhere. And then you come back to it and it'll either be gone or it'll go away the next time. And we've had people at seminars literally take their hand on a vinyl table and rub it just like that and leave a water trail beforehand. Do this and 5 or 10 minutes later, dry, absolutely dry. And it's just amazing to see this work. Travell and Simon note in their manual, trigger point therapy manual, myofascial pain trigger point therapy, that there's a point about 1 inch above the pubic symphysis, about right here. It really helps with enuresis and lack of control of the bladder. And I tried using trigger points on it, put needles in with acupuncture, and I got no good results at all. And I thought, I wonder what would happen if I tapped it sharply. So in those cases, I'd go 1 inch above the pubic symphysis, tap just like that. I'm telling you, 98% of the time, loss of bladder control is corrected very quickly, immediately, in most cases. We're going to talk about some that need some additional care to that. That in itself gets amazing results in most cases. We had a female doctor in Kansas City do it on a patient who was very young, in her 20s, and she was having to wear those diapers that you see on TV. 3 taps. She went home. She said, "Oh my gosh, my bladder didn't leak all the way home." 2 weeks later, my bladder still isn't leaking. And she called me up and she said, "This is just amazing." Well, I just adapted what was in Travell and Simon's, and it's amazing. Now, there are some cases that are much more difficult than that, but we're going to discuss that in just a few more frames. Now, here's how to stop a seizure in progress. Most acupuncturists teach to go right where the nose meets the upper part between the lip here. However, that's pretty good for some headaches. Matter of fact, when you lightly press there with your thumbnail, you feel sensations going over the whole head. But the best spot is where the teeth meet the gums, right between the eye teeth right there. And the best way to do that is turn your thumb on its side and press like this. Now, when you do it, you have to hold the back of the head so that the patient can't get away because they're in the midst of a seizure. So you jam it in, you hold the head very tightly. The seizure will stop in 15 seconds when you do this properly. Now, what do you do to keep the seizures from returning? Well, you take the small ball tip prod and you lightly go all the way up the midline. And I've found active points all the way to the middle of the forehead about here and all the way down to just under the chin here. You go over it once, just a little bit deeper than skin resistance, and you stretch the skin lightly for about 20 or 30 seconds. And you go back on the points, and anything that's especially sensitive, we don't care if it's just a little bit sore or tender, anything that's especially sensitive, You press until the skin resistance stops you this time. You don't try to go past it. And as you're holding it, if it doesn't start to go away within 10 seconds or it flip-flops around, then you get off of it for 20 or 30. Then you go back to it and it'll be gone or it'll go away. If it does start to go away, you just hold it until it goes away. On top of this, you put the patient on a minimum 30% fat lipid diet. And we show you the evidence for that in medical literature in part 4, so don't miss part 4. Large intestine 4 is the most used acupuncture point in the body. The way you find it is to close the thumb against the index finger. And you go right in the middle of the meaty part of the finger and you point toward the pisiform of the hand. That's how you activate it. Some acupuncturists, that's the only point they ever use in the body, and they get magnificent results on everything. The reason is, I think, is if you look in Chusids, the area that controls this comes directly from the base of the neck right over the stellate ganglia, which controls all the circulation in the body. Lung 7 is found basically going to the styloid process of the wrist and going over about a third of the way. And you've searched maybe a little around it and you find a sore spot. May only be active on one side, may be active on both sides. You just press lightly but firmly until you find the sore spot. And you can use this to get rid of excess fluid anywhere in the body, but especially right after surgeries. To get rid of tooth pain, I found it useful to go into the first dorsal interosseous muscle between the first and second metatarsal, or between the second and third metatarsal on the second dorsal interosseous muscle. Basically, you press lightly but firmly, and you're looking for the most sensitive spot in either of those two muscles, whichever the most sensitive spot is between them, and usually it's going to be up to the top in the proximal end. You hold a light but firm pressure because the stomach meridian comes up from here and goes up below the eye and then wraps around the teeth over to the temporomandibular joint. This will relieve pain in any tooth or gum. Now, sometimes you have to activate the pain, such as the patient will say, well, it only hurts when I have ice on it. So you get some ice, you put it in there, tooth is singing, then you go and put pressure on that point and it will relieve the tooth or gum pain. Now, I've had reports back from a doctor said, well, I had an infection in my tooth, and when I did it, not only did it relieve the pain, but it got rid of the infection too. I didn't come up with it for that, but that's what the report is back on it. When we consider the tooth and gum pain, I was working on a patient, and I tend to pop jokes while I'm working on a patient. So her husband was sitting over there, and he was laughing, and he was saying, please stop, it hurts. I said, I know it was bad, but it wasn't that bad. He said, you don't understand, I just had a molar removed 3 hours ago and it's killing me. Every time I laugh it jars it. And I said, okay, you're next. He said, no, and I said, don't worry, I won't touch it. Now you got to understand this guy, he hated all doctors, but he kind of gave in because I'd helped his wife with a lot of things nobody had helped. And so basically a couple of the rules of acupuncture are 50% of the time you treat the opposite side or the opposite end of the body to take care of the symptom. And another rule is an acupuncture meridian mostly affects what it's named for and where it courses to. Well, the stomach meridian goes up basically from first or second toe area, and you got to understand that the meridians flow one into the other. So we're pressing up or we're pressing in the feet, and it goes up and takes care of tooth pain. So I pressed on the most sensitive area between the first and second dorsal interosseous muscle, and within about 2.5 minutes, surgical pain from removing of a molar 3 hours earlier was totally gone, about 2.5 minutes. I said, how's that? And he said, pain's gone, but there's swelling in my tongue and my gum. So we went to lung 7, which takes care of surgical swelling, and we pressed on both sides, and it was only active on the surgical side. So we pressed lightly but firmly and held on to that. About 2.5, 3 minutes, all the swelling was gone out of the gums and out of the tongue. And I went to his dentist a couple of days later, and the dentist had told him he was going to be in severe pain and swelling for about 6 weeks from that surgery. So he related to the dentist what happened, and the dentist said, oh, I know all that stuff. He looked at him and he said, why'd you let me suffer then? You know, he knew that the dentist was lying about it. Now go forward about 6 months. The wife calls me, and she said, I remembered what you did for my husband. I just had a deviated septum corrected, and could I come in? Could you help me? And I said, well, come on in. So she comes in. The way they take care of that is they take a chisel and a hammer, and they break the septum, and then they reset it. And this is all flapping until it heals up. Now she had 2 black eyes from the procedure also. So she was in a lot of pain and swelling. So for that, I went to the large intestine 4 point, and it was active on both sides. And it comes up and it crosses over like this, so I figured that would be the best point. So I put a light but firm pressure on large intestine 4, pointing toward the pisiform on both sides, and it was painful on both. And in a couple of minutes, maybe 2.5, 3 minutes, about 80 to 85% of the pain was gone. It kind of stopped there. Then I went to lung 7 on both sides. It was active on both sides, so I lightly but firmly pressed that. About 2.5, 3 minutes, the swelling was down about 80 to 85%. So I had her come back the next day. It improved more. Next day, totally got rid of the pain and swelling on the 3rd visit. So she goes back to the surgeon, walks in, the surgical nurse was there, couldn't believe it. The black eyes were gone. She obviously was in no distress. She said, what happened? The patient told her. She said, can I have his card? I said, yeah. And she gave her one of my cards. Goes into the surgeon. He was aghast. He'd never seen anything like that before. And he asked for my card. Now, they told her that she was going to be in pain and swelling for 12 to 14 months after that procedure. Took 3 visits, about 3 days after that procedure was done. We had her totally out of pain, totally out of swelling, just by following those principles. Now, if somebody has full spine pain, you want to go to the middle of the back of the knees. So you bend the knee and you go about in the middle. I think that's bladder 54. You're going to press there, maybe a little bit to either side. You're going to find a sore spot. You're going to hold lightly but firmly. As you do so, you ask the patient, tell me when you feel the area start to relax, tell me when you feel the pain start to subside, and then when all the pain is gone. Now, when I first showed this is called Wu Chung or Wee Chung. When I first showed this in Salt Lake City, a chiropractor held his hand up. He'd been in a really bad auto accident, either 22 or 24 years earlier. Had all the therapies, all the adjusting, no one had helped the pain. Held this on him. I think it took less than a minute, and all of the pain was gone from that long after the severe auto accident. It was quite amazing. We've seen this played out over and over in practice. Now, the low back pain point is the second sacral spinous or tubercle, about right here. And you can put a light but firm pressure there, stick a needle in it, and just hold it lightly but firmly, and low back pain will go away. And I've had this work in maybe a half dozen cases. Usually other things work a lot better, but it has worked in those circumstances. So keep that in your armamentarium. Now for shingles pain, chronic shingles pain, you want to take the small ball tip prod, and basically the pustules, there are three types of shingles. One is it lasts about 3 weeks. So somebody calls me and say, I have shingles, can you help? And I say, how long have you had it? They say 2 weeks. I'll say, just wait a week, it'll probably be gone. 95% of it's gone. Somebody calls me at 2 months, they say, I have shingles, can you help? I say, wait a month, it'll probably be gone. 95% of those are gone. And there are people who have it years and years and years, and that's chronic shingles pain. So basically on that, the pustules have broken and now there's scar tissue there. You take the small tip prod and you go a little bit deeper than the skin resistance, just like this, and you stretch the skin for about 20 or 30 seconds, and you go back on it. Most of the pain will be gone. If anything is especially sensitive, and I don't care if it's a little bit tender or sore, leave those alone. If it's especially sensitive, you put a light pressure until the skin resistance stops you this time. If it starts to go away within 10 seconds, just hold it until it goes away. If it doesn't go away at all, or it flip-flops, within 10 seconds you get off of it for 15 or 20, or for 20 or 30 seconds. And when you go back on it, it'll be gone, or it will then go away. I had two older ladies in their 60s bring their mother in, had chronic shingles for 28.5 years on her side. That's all I did on her. And in a space of about 1.5 minutes, we had all the pain gone, doing what I just described. And it was a patch about that big. Now, if somebody has regional pain syndrome, otherwise known as reflex sympathetic dystrophy, there are a couple of different approaches to it that have amazing type of results. Let's say that this leg has that. Now, when you have that, then just the lightest touch can be agonizing. So most of the time you don't even want to touch the part. However, you may want to just lightly brush it. I've had students of mine, doctor students, who did that, then go back seconds later and they could touch it very easily. Another thing would be to brush the opposite side. And it's not a rub, it's a brush, just like brushing dandruff. You're not touching it very tough at all. You don't need to, you just need a drag of the skin. Also, you do the same on the upper extremities on the forearms, which correlate with that part of the legs, which you'll see later on in this course. You can also take the small ball tip prod and not go on the side with the regional pain syndrome, but go on the opposite side first and then on the forearms. You'll find that very quickly, usually within seconds, you can touch and the person isn't in agonizing pain for the first time in years. I had two offices, one in Dallas, one in Houston, and I would drive about halfway on Wednesday night, stay with some patients, we'd stay up and talk at night, and I'd head out to Houston early the next day. One day I get there and the wife said, "Oh, my tongue has been burning since yesterday. Is there anything you can do?" I said, "What happened?" "Oh, we had Mexican food." I said, "You had salsa?" She said, "Yeah." I said, "Was it any different type?" "No, it's just the same we'd always had." So I said, "Give me your hand." And I pinched in the webbing of the hand. Now the webbing goes up to the next knuckle. So I pinched around the last one, nothing. This one, a lot. Very painful. That was the only one. So I pinched, lightly but firmly held every position, and all of it was very painful. And as I pinched and held, and the pain went away on the web, all the pain went away on the tongue and the mouth. So that helps burning tongue, burning mouth syndrome. Now, same thing goes for the pelvis, only in this case it's the webbing of the feet. So I had a female patient come in complaining of burning in the pelvis, pelvic organs. So I went down to the webbing of the feet, which also goes up to the next knuckle, and I pinched in the outer toe on one side. And then this one, there was severe pain there, and there was severe pain in this one. So I pinched lightly but firmly and held in each position until the pain went away. And as I did this, the pain dramatically went down in the pelvis, and when I finished getting the pain out of those two webs, all the pelvic pain was gone. So if you have any type of burning pain in the upper body, go to the finger webs, and don't forget to pinch up to the next joint and follow it all the way around. You never know which ones are going to be the culprits. If you have lower body burning pain, and pain in the pelvis, for example, you go to the toe webs and you pinch and hold there. And that will take care of the burning pain. When you have a patient that's had a stroke and their arm is curled up, then you put a light traction on the arm and you tap on the infraspinatus reflex, and that is where the spine of the scapula meets the inner border of the scapula. And you tap there, and this has the effect of extending the arm and externally rotating the arm. If that doesn't work all the way, you tap on the triceps. Now for the hand that's grasping, you hook your fingers around the fingers of the subject. You take the small end of the small tip probe and you tap gently in the middle of the hand. This is a clasp or grasp reflex. As you're tapping, the fingers just open up. When a person with a stroke has a rigid leg such that you lift it like this and the knee won't bend, what you do is you put a slight upward pressure and you tap the middle of the back of the knee, and the leg will release within seconds, just 4 or 5 taps. In the Archives of Internal Medicine, Volume 30, 1922, it states that there are several different cardiac reflexes from skeletal afferents, such as from the mouth and from the pharynx, from the abdomen, from all the abdominal viscera. And get this, you can correct the cardiac rate from either slow or high by stimulating afferents anywhere in the body, almost any afferent nerve. So if someone goes into cardiac arrest, just start slapping them immediately. I gave this at a seminar. I got a call the next Tuesday. Doctor said a female, I think in her 40s, was walked in the front door, was walking toward the front desk, collapsed, the heart and respiration stopped. You remembered what I said at the seminar. Immediately just started slapping her, and her breathing started and her heart started again. Saved her life from something written in the early 1920s, just because I went back and found it and started telling it to doctors like him. And you may have some unexplained issues going on with patients. They may have something wrong with their eyeglasses. We know that when a prescription is gone, people can get headaches. I had a patient that had severe shoulder pain and weakness, and I wasn't getting anywhere with her. And one day it occurred to me, I'd never tested her with her glasses off. Took her glasses off, all the pain went away, all the weakness went away. Put them back on, came back again. Had her close her eyes, it went away and the strength came back. I said, there's something wrong with your prescription. So we took her to an ophthalmologist and found out that we knew that she was far-sighted, but they had given her prescriptions where her seamless reading area was up too high, a ½ inch, on the side where her shoulder was bothering her. So we went and had new prescription glasses because they ground them in the wrong way. So she was looking through and seeing near vision on that side where she should have been seeing far vision, ground for far vision. And after that correction was made, her shoulder cleared up entirely. Had another gentleman that he had been a scholarship athlete in track for years, and all of a sudden he starts out and he starts going and jogging, and he's in his 40s now, and he jogs 2 or 3 steps and his buttocks clamp up so hard that it's painful. He could walk, he could sleep, nothing bothered him except jogging. And it went on for years. And came in, I couldn't get anything. And I remembered the woman, so I sent her to the therapeutic optometrist, and which is what I meant to say the first time, not ophthalmologist. And took the glasses, put them in his reader. He said, I see you're farsighted. He said, no, I'm nearsighted. I've always been nearsighted. Put him back in his reader, farsighted. They had ground the glasses for a farsighted person. Somehow his vision accommodated to it and caused this problem. Went back and had it corrected. This was at Pearl Vision Center. Had the therapeutic optometrist grind him this time. When it was corrected, then it could run fine. Didn't realize that was a problem. That was me. That person was me. I didn't realize it until this happened with this woman. Had a guy come in and he was having skipped heartbeats, and it was something that we're going to show you later. We got the heartbeats corrected about 20%. And then I remembered myself and this woman, and I said, I think you got something wrong with your glasses, because he was wearing glasses. Sure enough, the prescription was wrong. And I learned from this therapeutic optometrist, I said, what's the difference between a regular optometrist and a therapeutic optometrist? And he said, well, for example, we do studies, and ADD and ADHD can be caused from wrong prescriptions. And when I showed him these things, he had no idea about these either, so we found some things that weren't even in his literature, and he started using them. I had a patient refer in another patient. The other patient drove in 550 miles one way. When he came in, he was in a wheelchair. and he was pretty heavy set, and I wasn't really expecting that. And I said, okay, why are you here today? And he said, well, I have full foot drop on one side, about half foot drop on the other side. And I decided to myself, because I had never once in my life helped a foot drop, and I didn't know what to do. So I kept my cool. I thought, okay, we're just going to put them on the table and do an exam, see what comes up. So we had him lay face down like this, and I brought foot up and I jammed it into the back, and his foot just started going like this. And I'm sitting here thinking, that is wild. I haven't seen anything like this. And his wife was sitting over by the corner of the table. So I let it up. I did the other side, and it started doing the same thing. And it was flexing and extending wildly. I held each side about 5 seconds. As soon as I let it up from jamming it into the buttocks, as in Nautilus, Yeoman's, Eli's, then it stopped. So when it was fully into the buttock is when it happened. So I did it again here, and he was feeling it. And his wife said, what's that? And I said, oh, it does that sometimes. I had no clue what was going on. So I did each side 3 times for 5 seconds. I had him sit up. I said, okay, lift each of your feet up. Both of them went up perfectly, and he stood up and he walked. The only reason he said he couldn't walk is because he had the foot drop. On both sides, he stood up, and he hadn't walked like that in 7 years. And it was just astounding. Everybody except one person I've done it on since that's taken care of the foot drop. A couple of times it took more than one treatment to fully resolve it. I had a doctor in Salt Lake City who'd had MS for, I think, 14 years. He was walking with his foot out to the side because of full foot drop. I did this on him, and immediately he could walk straight with no foot drop. The manager of that motel had the same thing, and she had MS. Brought her in, did it on her, her foot drop went away. I've had people with partial and full foot drop, like I said, with the one exception, didn't do it. I thought, surely somebody has noticed this before. Lay on your back, please. So in Mazion's textbook, he notes that Strumpel's sign was to put the hand under the knee like this and flex up like this, and if the foot dorsiflex, that's a sign of an upper motor neuron lesion. And in both cases, it's a stretching of the patellar tendon. Apparently, they didn't think to use it as a treatment. So probably either way will work. The one that I've done, that's the way that I do it. And like I said, with one exception, it's worked every time. Most of the time you just need one treatment, and it's quite astounding. And I've had doctors call in, unbelievable. They said, it's taking care of foot drop. I've never helped a foot drop in my life. And they were just like me, but this got it.